Hi, everyone, and thank you for joining the WSPID podcast. I'm Linny Phuong, and I am a paediatric ID physician based in Melbourne. Thank you for joining us, everyone. Today, I have the pleasure of interviewing Professor Pamela Palasanthiran. She's a paediatric infectious diseases specialist with many hats. Currently, she's the head of infectious diseases department of Sydney Children's Hospital Network Randwick in New South Wales, Australia. And she's proud to say that she started her career in paediatric infectious diseases 3 decades ago. And this all started off with a PEDS fellowship at Duke University Medical Center in North Carolina, USA. Dr. Lesley Voss, who was a senior pediatric infectious diseases physician at Starship Children's Hospital in Auckland, New Zealand. Lesley spent 3 years of her ID and micro training beginning at the Mayo Clinic in Minnesota, USA. Professor David Burgner, who was also a pediatric infectious diseases specialist and researcher based at the Murdoch Children's Research Institute and the Royal Children's Hospital, Melbourne, Australia. Before we go on, I have lots of questions for you, but I would like to start by just asking you what drew you to pediatric ID?
Pediatric infectious disease in those days is not the same as it is now. It wasn't a specialty. It was, someone called it a Cinderella specialty. No one knew anything about it, and it was relegated, I don't know, to where it was. But it was a very intriguing and it interfaced with, so many other bits of infections, and I decided that would be what I'd like to do. And the fact that it's actually across the board, you don't own an organ, and you have to be very wide range and broad. I mean, that's really what interested me.
What drew you? Fantastic.
I've always been interested in sort of social determinants of health and families. And in fact, I did the psychology degree during my medical training. So I've always been interested in the patient and the child in the context of the family and the wider society. And then pediatric ID was always fascinating, that sort of interface between, the prokaryote and the eukaryote, and understanding that was, as always. So it was ideal for me, despite the fact that when I was starting out, there was a whole sort of group of us, a whole posse, who were just thinking there's no jobs in this. It's not really even properly a specialty. But no, it was just seemed such a natural fit for me that I really loved it.
It was pretty straightforward. Did the old pediatric training, had no idea what to do next. And then I had this amazing mentor who said, oh, why don't you do ID work? She was obviously an ID consultant, and I thought, well, there's nothing else that's catching my eye. So I thought, yeah, that sounds a good idea. I was in Auckland at the time already, so I did a year's fellowship here, and then I went to the States and trained in it, ID and micro. Came back and did research for a couple of years, and then I got a consultant's job. So it was more that it was the sort of right mentor at the right time.
Pamela, what challenges did paediatricians face when diagnosing and treating paediatric infections 30 years ago?
We faced a fair number of challenges in 1995, but by its very challenges, things have improved, and they've actually improved our lives now. In Australia, there was no pediatric infectious disease training program, which is why 30 years ago, we went overseas, and I think I joined the first wave of pediatric trainees that went overseas. And Cheryl Jones was one of my counterparts, and we went off to the States. I went to Duke, and Cheryl to Boston. But there were many others who went also to Europe, and including England. If I could talk about challenges in general, one of the main things was communication. Look, you and I are sitting now in one of the most progressive ways of communicating, which is online. But take you back only 3 decades, the internet was very much in its nascency. You now have the mobile phone, which is part of our appendage. But in those days, we didn't. So you can just put yourself back in that situation. People got you by this very archaic thing called a pager, if you even remember what that is. And look, you have a pager, but hello, there's no phone. So if you're on a ward, you got to find a free phone. But worse still, most of the time, and people know this who are infectious disease training, you're driving along or you're on the shopping center and there's no phone. And what you have to do, you have to find a
phone box.
Actually, a landline, a telephone box. I kid you not. The other thing too is finding experts. You now, anyone, they WhatsApp, they call, they email, they have online chats, and you can find an expert anywhere in the world. We had to rely on our consultants, our mentors. And actually, it worked very well. You actually saw a person, and they gave them your wisdom, and there was an art involved in that rather than all science. The only problem is you had to find them at their desk because they didn't have a mobile phone. And you had all find them in the office. So those were some of the challenges. And I guess just to make it more serious, we didn't have a mentor of consensus guidelines in those days. You almost had to make a lot of things up. Nowadays, we have a plethora of guidelines. And the last thing I would say for this is that diagnostics were a bit of an issue in those days. The PCR is probably one of the most incredible breakthroughs in medicine in the diagnostic world, but we didn't have that. We had to wait for cultures.
Yeah.
It took quite a while.
It's interesting thinking about this question. You know, there were some basic things even just at the level of the doctor without even the patient. And we used textbooks and journals. So we were always a little bit out of date with our data. It was really, really difficult to communicate with overseas colleagues. When I first started, I got a huge increase in HIV infected children as refugees. And I tried to talk to John Ziegler at Sydney, who had set up the HIV program initially before Palasanthiran arrived. And I had to go to a studio, a Vodafone studio, to do a video with him to discuss these complex patients. So from that perspective, it has changed dramatically, and it was really challenging at that time to be up to date with the latest information technology. When I started 30 years ago, we didn't have, a lot of the antiretroviral drugs. We didn't have some of the diagnostics, MRIs, things like that we didn't have back
PCRs.
then. Yeah, but then some things are still the same. We still don't have all the pediatric formulations we want.
Yes, of course.
We still have the off-label use of so many drugs. So some things have never changed and others have changed dramatically. PICC lines dramatically changed life.
Yeah, of course.
When I first started, it was all IV lines. We were losing IV access, treating a meningitis for 6 weeks, trying to keep peripheral IVs in. It was dreadful. So PICC lines have been a huge breakthrough, I think, in providing care to our children. But obviously I was in an era where I saw pre-Haemophilus vaccine. So that's been a complete change in our focus. We spend all our time dealing with children with bacterial meningitis, and now with the change in vaccines, Haemophilus introduction and pneumococcal, it's just changed our practice completely. So I would say vaccines, and of course antiretroviral therapy. That was a massive change.
Some huge
but then things that haven't changed, like TB medicines, hasn't really changed a lot.
Of course, vaccines obviously have been such a pivotal medical breakthrough. When we were sort of pre-Hib and pneumococcal vaccines, how many cases were you seeing, and sort of can you describe what the wards were like and what the mix of patients were at that time?
Yeah, I guess we were getting pretty regular cases of bacterial meningitis. I don't know, one a fortnight or something like that. But the Haemophilus cases were always so inflammatory, and so they would have subdurals that often start to get better and then they'd deteriorate, and fevers would go back up. We only had CTs initially, or you'd get drug reactions because they'd been on antibiotics for so long. They were really inflammatory. They were really complex and difficult to manage. And we had a meningococcal outbreak here in about 91 for about 10 years, and we were getting one every second day of meningococcal disease. Okay. So again, Bexsero has been a huge breakthrough in terms of vaccine, meningococcal C vaccines.
It's come along so quickly and fantastically. I mean, in a way, I wish I was a trainee now. I mean, the trainees can obviously speak much better of their lived experience now, but I mean, it is a fantastic, well-established specialty. It was a bit stochastic, I think. At least it felt like it to me in terms of training. I mean, we sort of sought out the best training where we could, and I think I was really lucky. But the formalized training and the education that we have now available, I think is really, and the curriculum and the support is available to everyone. So I think it's much more organised, and the academic structure that surrounds it is much more formal. And I think for Australia, we have we stand on the shoulders of giants. The giants actually happen to be quite short, Dave Isaacs and Palasanthiran and others, but they are giants. These are the people who kind of blazed a trail.
You've talked about HIV care and how that sort of was was kind of the headline into paediatric ID and infectious diseases in general. How do you think HIV care has changed over the last 30 years?
The late 80s, HIV put infectious diseases on the map, really, and that's how it all started. So I went on to do a Doctor of Medicine. It was the PhD equivalent, although people don't like that being described as that in those days for medical doctors. And I did it with John Ziegler, who, if people in the audience might know, was the grandfather of pediatric HIV in Australia. Really, he set up the National Pediatric HIV Service. If there's ever a public health venture that is seminal, the prevention of HIV infection, perinatal HIV infection, is probably one of the most significant in pediatric public health means. I was doing my research, and you may laugh, but it was the year that the PCR was coming to the fore, so I think it was 87 or 89, I don't know. But in those days, it was a really mystical a tool. And we in fact, we published on this, John Ziegler and I, on the use of PCR in diagnosing HIV, pediatric HIV. You couldn't use antibiotics, and that was the first bit. But in that space, John Ziegler also was the first who described the transmission of HIV through breast milk. And from that was a springboard then that led to a lot of studies sequentially over the next 5 to 8 years on the risk factors for HIV transmission from mother to infants, perinatal. And once you knew what the risk factors were, you could put strategies in place. So breastfeeding, cesarean section, eventually controlling the viral load, eventually the type of feeding. So now, fast forward, HIV transmission there was at 25% in the best of times, 50% if you also breastfed. We are now able to actually reduce perinatal transmission to less than 1%. That has just transformed pediatric HIV in high-income countries. We're obviously still having pediatric HIV in the LMIC countries, but even they, in some countries, are actually doing very well.
And the medicine, Dave, how do you think that's changed?
ID is continually fascinating. I never come off a week on call without learning loads. I think it's the best specialty. And I've had other specialist consultants say, I wish I'd done ID. The quality and the evidence-based practice is obviously, is developing at pace. So we're much more aware of having to have an evidence base where it's available.
Yeah.
And I think one of the things that ACID and ANSPID have done really well is to increasingly make sure that pediatrics is included in trials. That's so important that we're not just extrapolating, of course, from adult trials. And the days of children being little adults is a well-worn cliche, but we don't, people don't make that mistake so much anymore.
Yeah, no, that's fantastic. There's been some great developments and lots of interesting ways in which clinical medicine is changing, whether it's more immunosuppression to more drugs, hopefully more antibiotics in the pipeline, and changes in diagnostics as well. A few other people have alluded to. Yeah. You mentioned about communication methods. Pam actually referred to the same things about pages and landlines and not having, I guess, the evidence base at your fingertips. How did you navigate that evidence base when you were starting out?
Well, I think you just did use journals and textbooks and your own colleagues. So I think we often had to make just a best decision. And when we did get to meetings, I think it was really important then that we did get together with our colleagues and we often took cases with us to discuss them and say, what do you think? Networking even then was incredibly important, and it was often a little bit more sort of clinically based, and that we, really needed that to discuss cases and,
I'm assuming, Lesley, at that, during those times, was there a functioning sort of journal club type?
Yeah, absolutely. There's always been we've always done a journal club with our adult and micro colleagues, and that the adults had put that in place, and that's always been incredibly supportive. And of course, our adult colleagues were really good, particularly over managing HIV patients, things like that. So, and they had the same diseases. So, using our adult colleagues even back then was incredibly valuable, and we still do, obviously, with some diseases where they see more of than we do. And the journal clubs, we had our own updates. Those things have always and still remain an essential part, I think, of our processes.
So, Pamela, over the last 30 years, there's been some changes in terms of women coming through medicine. Are there any sort of changes in terms of systems, or were there any challenges going through the system as you were coming through? And what do you think? How do you think things have improved?
Well, that's great, Linny. First, we have to be cognizant that 30 years ago there were no pediatric infectious diseases departments, so there'll be many names that you might recognize, and a few of us had to set up services from scratch. So what that meant was that you were the only pediatric ID physician on. Well, that meant you had no cover.
Yeah.
And also, because there was no training program as yet, you basically didn't have any trainees to assist you. So if you can think of that as the start, that's how I came into this. And, you're always grateful when you've got a job. So 30 years ago, grateful for the job, 30 years younger, fire in my belly, all that sort of stuff. And actually, I came in without a family. So got the job, started a family, because the clock's ticking. You never think of this when you're training. And basically, in those days, this may sound appalling to you, but people like us did a 1-in-1 roster. So we were on nearly 365 days a year. Eventually, in 2004, I had my first fellow, that be Emma Best. And since then, including Emma, my wonderful first fellow, who's gone on to also do great and good things, better things. We've had some fantastic fellows who, with famous names and within pediatric ID. So what's different? The difference is, I think the system now is more cognizant of work-life balance. Mm-hmm. They're more cognizant of work limitations. Yeah. Obviously, there are rules and regulations surrounding how much you can make someone be on call and so on and so forth. So I think the system's much better now.
Thankfully, much better. And thank you to all of you who sort of helped push the system and shape it so that all of us coming through could have a better work-life balance, perhaps.
We've developed a formal pediatric ID training program.
Yes.
So when I started, yeah, absolutely. When I started, we just did whatever, and then called ourselves a pediatric ID person. I mean, interestingly enough, what I did do would have fulfilled current criteria, but it was much more ad hoc. You just basically said, I really like to do this. You maybe did some time somewhere. And so formalising a training program was amazing, that really made us become, I think, a more accepted specialty. So that was a really crucial part, I think, in becoming accepted as a subspecialty. Prior to that, people said, ID is just part of general pediatrics.
Right.
Anybody can do ID because it's just gastro and things like that. So I was actually trying to say, no, it's not just gastro. In fact, gastro really isn't us. And formalising that training program really, I think, started to give that acceptance as a subspecialty.
In terms of WSPID and I guess what you've experienced being on the board and being on the education committee, what do you see as some of the perhaps challenges or opportunities for WSPID over the next decade?
I think WSPID's really matured much more and really defined and is continuing to define its true purpose, really. And I think, I was particularly involved in the education and with a fantastic education committee that included a lot of input from young WSPID. We started to formalize the education program, the online education that is really thriving now. And that has been really important in terms of reaching, as I said, practitioners in resource constrained settings where education with it's obviously becoming much more available now, but we were particularly interested in targeting and making the education appropriate for those practitioners. Many of whom are not formal ID, not only ID physicians or practitioners, just, because of the circumstances in which they work. So I think that is clearly an ongoing challenge. I think one of the challenges was trying to get ongoing engagement from really busy people in a variety of settings. So making sure that each society is truly represented, because there are, behind each society, there are hundreds, if not thousands, of practitioners. So I think, genuine, sustained engagement from each of the societies is really important, and being creative about how that might be increased. We did pretty well, but you want to, in a way, kind of take it beyond a few enthusiastic individuals and engaging the grassroots. And the societies vary a lot in terms of their overall structure and their ability to communicate with their sort of grassroots members. A lot of them don't necessarily have formal members. So I think that's the ongoing challenge, and making the content of the education appropriate and relevant to the needs of all the different locations.
Absolutely.
I think the other thing is financial sustainability. There's obviously a tension between commercial sponsorship from pharma and other agencies and independence, and I think that's something that WSPID has got much better at.
Dave, you've mentioned a few times some of the giants of paediatric infectious diseases, particularly in Australia. And you mentioned Dave Isaacs and his contribution to your sort of, I guess, the start of your career. Can you speak to some of his contributions to whether it was Paediatric ID in Australia or ANSPID and WSPID more broadly?
I don't know if Dave was I think he was the first person to sort of try and bring together the ANSPID group. I didn't go to the first WSPID meeting, but I went to one of the first ANSPID meetings, and just remembering feeling like I belong here. I really, and it always a fantastic relationship with the immunologist. That's something that was sort of, because you don't have one without the other, in my opinion. So Dave really developed that and started to develop the structure. And then from that, ANSPID developed much more of a structure, really well supported by ACID, the Australasian Society for Infectious Diseases. And then I was on the board for ANSPID and then chair. But there's been lots of us who've been involved. Since I've been involved in ANSPID, I also was on the WSPID board for a couple of terms, and then the education officer. So I could see the contribution that, Dave had blazed the trail in terms of setting up ANSPID, and then ANSPID has really made, I think, important contributions from all the different people involved to WSPID. And there's really, we've had two presidents, Jim Buttery and Asher Bowen, but a lot of people also on the committees and the reps and the young WSPID, yourself included, making, really helping set the agenda and helping WSPID evolve into a much more mature organisation with much more of a focus on education and outreach education to resource constrained settings. Finding ways to do that, but also continuing to engage the next generation, because the young guns quickly become old farts, and making sure that the next generation are setting the agenda, really, because the topography of ID and obviously the world and the funding, etc., is changing so rapidly. I think you've got to be responsive to the changing conditions.
From all of us as the newer generation, thank you for for paving the way for all of us and ensuring that we have amazing training and have had that really great start in paediatric ID. Is there any advice that you would give new paediatricians or new paediatric ID specialists in terms of starting their career today?
I would say take your time. Mm-hmm. Take your time about thinking about what you really want to do, where you want to be. It's a journey. You don't need to race to get to the end.
Sometimes I feel like it's like someone giving you advice when you got a new baby. Like, you get so much different advice that clearly none of it's true, and yet it's all true. Being flexible in terms of, what your ideal job is. I did 6 years as a general paediatrician. And I'm glad I did, but and I think it probably made me a better PID physician, but just being a little bit flexible, seizing opportunities when they present themselves, even if it wasn't part of some plan. Things I wish I'd done. I wish I'd got myself a mentor. I mean, I've had some fantastic mentors, but a mentor who was a little bit separate from my career, academically and clinically, earlier, and a mentor who wasn't trying to create me in their own image. I've done a lot of mentorship, and I think just having someone a bit independent, a bit dispassionate, who's really able to meet with you. And I think that's something we've tried to do through the research workshop that we set up as at the meeting. The PIDS group particularly had some experience through the Pediatric Academic Societies of speed mentoring, and we've tried to do that mentoring. And I think WSPID is really well placed to be able to facilitate that, especially, between settings, having a mentor in your own region, but maybe one overseas as well.
The first thing I would say to any trainee is you really got to love what you're doing. If it becomes a chore and it's a burden, maybe have a rethink, but you have to love what you do. The second thing is you have to find a mentor. That's a thing that will travel with you in your training. It's someone whom you have trust in, who actually also has your back. And then I loved research, and I loved doing my higher degree. If you do one, get a good supervisor. It comes again to having a good mentor, doesn't it? Yeah.
The biggest mentor I had was Professor Diana Lennon, who unfortunately died very suddenly a number of years ago. She had trained in the States. And she was very passionate about pediatric ID. She just encouraged me. She gave me ideas, papers to, research topics to write up. She was always there, but she was also sort of saying, you need to show me that that's what you want to do. And another one I had in the States, an older lady, Dr. Kathy Rhodes, she was also a bit like that, saying, we'll provide this part, but you have to do your bit to it. It's a two-way street. And I think both of them were sort of saying, here's your opportunities, but you need to take them forward.
Dave, I am interested in hearing final thoughts around what you think pediatric ID will look like for the next decade or so. If you foresee any challenges or things, what are your sort of musings?
Yeah, it's a great question. I think embracing the new technologies is obviously going to make a huge difference in terms of diagnostics. We do a lot of research around omics, mainly host omics, but I think, diagnostics, not only in terms of microbial diagnostics, but understanding diagnostics from a host perspective. There's a lot of work obviously coming out of Europe and looking at that. And I think that will really take off, and that, and scaling that to bedside, to make it accessible in outside of high income research settings, I think will be really important. It's less of my area in terms of knowing the sort of how those technologies will impact on AMR and stewardship, but I think that's going to be absolutely key.
Yeah.
The other thing I'd love to see more of is actually embedding research into clinical practice as the norm, rather than as sometimes it's seen as a luxury or a bit of an add-on. But, oncology or, HIV do that very well. We're less good at it. We're less protocol driven. ID physicians can brush their teeth without a protocol, unlike neonatologists. I'd like to see clinical research become embedded so that we have living evidence. The thing that really excites me is the new diagnostics, I think, because we struggle so much for the diagnostics. And I would hope that in the next 5 or 10 years, that's going to undergo some revolution.
I love your points about living evidence and embedding research. I also think that your thoughts around how some of these exciting new technologies might change pediatric ID is a really interesting thought for the next few years. I guess we'll wait to see what happens. So we're wrapping it up now. Thank you again to Pam, Lesley and Dave for your time and insights into a picture of the evolution of pediatric ID in our Australian context. I know that there'll be heaps of pearls of wisdom that people get out of this conversation. And so thank you all again.
It's been interesting, and it's really good to think back on the past, actually. Thank you, Linny.
You're welcome, Linny. All the best to everyone out there.
No, thanks, Linny. I mean, and thanks for all yours and everyone else's work for maintaining the energy and dynamism of WSPID. I think it's I think it's great.